Sekian. Mana ni? Mana? Apa ada webpad sebenarnya?
Webpad tak ada.
Ini apa?
Ada Zoom.
Zoom. Sorry, webpad
Kita guna Zoom.
Zoom eh?
Hmm.
Apa slide saya tu? Yang paling bawah tu. Apa tadi? Paling bawah ni. Coba itu.
Ya Allah tu. Ya Allah.
Okey dah.
Boleh.
Ya.
Yes. 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 Boleh. Yes. lalu sudah apa tadi sudah apa yang tadi apa sebagai tuan lah itu. Pelaku lalu kalau tes satu dua tiga. Kalau tes satu dua tiga, satu dua tiga.
Test. Test. Okay. Ladies and gentlemen, we are about to begin shortly. Please be seated and ensure your mobile phone are switched into silent mode. For attendance, kindly scan the QR code displayed on the screen or use the attendance link via WhatsApp application that has been distributed through PIC in respective department. For participants from district hospital who joined this CME via online, any question are welcome through the chat box in YouTube channel. Assalamualaikum warahmatullahi wabarakatuh. A very good morning to our honorable guest, Dr. Puteri Nurbaya binti Muhammad Ismail, Deputy Hospital Director 1, Dr. Tengku Anas Fathi bin Tengku Ahmad, Deputy Hospital Director 2, Head of Department, Specialist, Medical Officer, nurses, and the rest of respected HRPZ staff. First and foremost, I would like to thank everyone for allocating your time attending our CME session. I am Dr. Farah Wahida from ONG department, will be your MC today. Without further ado, I would like to invite Dr. Nick Muhammad Shahrul Hafizi, our ENT specialist, to present today's CME with the topic foreign body in ENT. Please welcome.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh dan selamat pagi. Yang berusaha ketua-ketua jabatan pakar-pakar perunding, pakar-pakar pegawai perubatan serta semua warga kerja Hospital Raja Perempuan Zainab II Kota Baru. Saya Dr. Muhammad Shahrul Hafizi, BAwan, mewakili jabatan ENT akan membentangkan topik foreign body in the ENT. So, this is my topic for today. Kenapa saya memilih topik ini sebagai pembentangan CME mingguan di HRPZ adalah kerana topik ini adalah sangat dekat di hati saya serta semua warga kerja jabatan ENT terutamanya. Ini memandangkan foreign body in the ENT is, boleh kata, setiap hari kita jumpa, terutamanya foreign body dekat telinga, hidung, serta di bahagian tekak esophagus, dan juga kadang-kadang kita terima kes yang foreign body in the airway. So without further ado, okay, this is the outline of my presentation today, in which I will start with the introduction, foreign body in the ear, foreign body in the nose, foreign body in the throat and esophagus, and last but not least, the foreign body in the airway. Okay, so for the introduction, foreign body ada more common problem in the children, usually in the preschool children, and then children usually less than 4 years old are more susceptible to the foreign body injuries due to the lack of the molar teeth, oral exploration, and also poor swallowing coordination. As we notice in the ED and also the ENT, usually the child less than 4 years, the common that we encounter because of their nature of exploration. So they tend to put the foreign body, especially the small toys, as well as the small things inside their nose, ear, as well as the sometimes in the mouth. Okay, but for the foreign body in the adults were mainly food related, whereas the pediatric group primarily consists of the food and also the small objects. In the pediatric population, seeds or nuts represent the most typical foreign body in the ears and nose, and then closely followed by the plastic toys. So this is the diagram show the size of the foreign body, in which kita boleh tengok the paling common foreign body lodge berada adalah dekat dengan telinga, accounts about 44%, as well as followed by the nose, 25%, pharynx and esophagus. And last but not least, the most rare is the foreign body in the larynx. This study published in the Sarawak ENT department. Okay, so we go for the types of the foreign body. Usually, type of foreign body can be divided into the organics and inorganic. For the organics, the foreign body tends to be more irritating to the nasal mucosa and also the GIT mucosa, and may produce earlier symptoms. The organic foreign body can be divided into the animate, for example, maggot, insects, or any living creatures, and inanimate, such as the seed, nuts, leaf, and also the flowers, small flowers. And then for the inorganic, usually the material typically consists of the plastic and the metals, and these materials are often asymptomatic and may be discovered instantly, except for the bottom batteries. The bottom battery is the closest foreign body, in which it is one of the emergency in the ENT. And then for the non-corrosive, such as the small toys, bead, wood, pencil eraser, as well as the rock. So we can see the classification, and then usually the foreign body related to organics, we more tends to be more attention because of the more complication arising from it. Okay, from the picture we can see here that for the organic animate foreign body such as the tick, this is the one of the creatures, small creatures that we always encounter in the ENT department. And then for the organic inanimate, such as the nuts and beet. You can see from the picture, this is the all type of the body that we previously encountered and that I attached in my slides. Okay, for the inorganic, you can see the bottom batteries, the corrosive bottom battery. This is the rare case that we encountered in our department, in which we remove the bottom batteries from the nose, the nose. And then the other pictures show the inorganic non-corrosive that we can see, such as the coins, the bead, as well as the pink cat. These are all the cases that we encountered before. Okay. Okay, for the symptom usually the patient presented with related to the size of the foreign body that it lodged. For example, if the foreign body in the ears, patient might have no symptom. Maybe patient have the otologia, buzzing or blockage in the ear, and occasionally the patient will present with the dizziness. And for the nose, usually patient will present with the unilateral rhinorrhea and cacosmia, unilateral rhinorrhea, and also patient might have the bilateral rhinorrhea also as well, and with the fever. We will go through precisely all the presentation in the next slides. Okay, so we start with the foreign body ears, as this is the most common foreign body that we encounter in the ENT. Okay, for the foreign body ear, the presentation is related with the type and nature of the foreign body. If the foreign body is the inorganic subject, usually it is asymptomatic, but for the sharp object, the patient may complain of the pain and bleeding as the object may abrade the ear canal. If the foreign body is the seeds or peanuts, patient may have swelling. The foreign body may swell with water and obstruct the canal, causing the pain also. And for the insects, it may injure the canal or the tympanic membrane by stretching or stinging. And the patient may have hearing loss, maybe due to the blockage also. And later, subsequently, it can get infected if the foreign body still lodged at the ear, cause the erythema and swelling of the canal, and for smelling discharge may be present also. Okay, the most common ear examination that we perform is the ear otoscopy. It is widely available in all primary care as well as the ED. And for our ENT, we have ear examination under microscope. Okay, for the treatment of the ear, okay, if the foreign body is a living foreign body, we always advise our colleague in the primary care don't ever probe the ear with tools, because it's risk of pushing the object further into the ear and damaging the fragile structure of the middle ear. Instead, we ask them to instead of oil for an insect, because instead of any mineral oil, olive or baby oil into the ear, its purpose is to kill the insect, thus reducing the irritation. And after that, refer to ENT for the removal. And then for the removal of the object, a few methods can be used to remove the foreign body that we have in our ENT clinics. Okay, this is the first example of the instrument that we have, in which we have a forceps by grasping the foreign bodies. And we also have hook removal, in which the hook anchor is placed behind the foreign body and gently draw the foreign body outwards. I will show you all the picture after this. Also, we have the suction, in which we gently remove the foreign body by suctioning. And the least common that we use is irrigation or syringing. By flushing the foreign body as the water come out of the ear can be done if the foreign body is small and the TM is intact. So for the patient with the any ear infection or perforation tympanic membrane, it is contraindication to perform the irrigation or syringes. And the ENT, we have microscopic removal under ENT, under general anesthesia, in which we will push the patient to the OT and try to remove it. Usually the child with special care, like syndromic child, we tend to remove the foreign body by putting them under general anesthesia, so that it will be much easier and convenient for the patient and less complication. This is the foreign body this is the instrument that I mentioned before, in which from the left, there's the suction, followed by the crocodile forceps, and also a few instruments such as the hook also. Okay, this is the picture. You can see the first picture in which the ENT surgeon will use the crocodile forceps to pull out the foreign body in the ear. The first picture is that is the insects inside the ear canal. And the second picture shows the hook that used to remove the foreign body. So we go with the second foreign body, in which foreign body in the nose. Okay, for the presentation, usually the patient will complain of the blocked nose through the affected nostril, feeling of something in the nose, unilateral false smelling discharge, bloody nasal discharge, and then for the infant, usually there are more irritability, particularly in the infant. So for the examination, it is usually the parent as well as the caretaker can see the foreign body by tilting up the tip of the nose. So for the foreign body that lodge anterior part of the nose, they can see the foreign body. But for the foreign body that usually located or lodge more deeper in the nose, usually we can visualize them by performing the 0-degree scope. And also in ENT, we have anterior rhinoscopy, in which you use the tulicum speculum to visualize the foreign body. That's like in the first picture, the nose picture. That's the tulicum that we use to visualize the foreign body. And then the last, we also sometimes we need the X-ray to see whether the foreign body, the type of the foreign body, and also the quantity of the foreign body. This is the case of the suspected bottom batteries or also the metal inside the nose. You can see from the second picture, that's the picture of ENT-MO. That time, we using the 0-degree scope to visualize the foreign bodies. Okay, and then for the treatment, removal of the foreign body in the nose is done in the clinic setting usually. And then the instrument that we use, we have a few instruments such as the rose cannula, and nasal forceps, and also if the patient is not cooperative, we will put patient under OGA and also remove the foreign body under general anesthesia. Okay, as you can see from the picture, that is the mother, the picture of the mother holding the child. That's the optimal position that we ENT-MO position the patient so that we can easily remove the foreign body. And then we always remember, especially ENT, and then we encourage our ED, MO, and especially also to try to remove the foreign body one attempt only. And if they cannot remove the foreign body or the foreign body is very difficult to remove, we advise them to refer directly to ENT. Okay, there is a few instruments for nasal foreign body removal. From the left, the foreign body is the rose cannula, followed by the suction. And the third one is also the suction, and the last one is the forceps. All these instruments are usual instruments that we use to remove the foreign body from the nose. Okay, I would like to share with you all one case of foreign body in the nose in which the child presented to us previous year facts. Okay. 4-year-old child complained of the bilateral nasal blockage with false smelling brownish rhinorrhea and also fever. Previously, the parent sought treatment already from general practitioners. However, the condition has not improved. That time, the child was given the antihistamine as well as the antipyretic for his condition. And then this case was referred to us. During the nasal examination, it showed false smelling crusted brownish lesion covered mucus at the anterior part of both nasal cavities. Okay, so in view of the we see the lesion, we want to rule out whether what type of foreign body that time. So we proceed with the X-ray, the multiple view. So the X-ray show a double ring signs or halo sign shadow inside the nose, which is suggestive of the bottom batteries. However, the AP view of the X-ray also show two shadows of the foreign body embedded inside each nostril. So we always remember that even though the typical presentation of the nose foreign body usually unilateral false smell, unitary blockage, as well as the unilateral rhinorrhea, but the child may complain with also with the bilateral discharge as well as the false smell. So for this case, always remember that X-ray must be done to know whether it is what type of foreign body, especially the metals and also bottom batteries, and we want to see whether the foreign body single foreign body or multiple foreign body. So from the X-ray, you can see that's the foreign body located both of the nostril, and the foreign body show the double signs, double ring sign, which typical presentation for the bottom batteries. So for this child underwent the examination under anesthesia, bottom battery removal, and nasal toileting. From the picture, you can see that's the bottom battery there. Two bottom batteries, which are already corrosive to the mucosa. And then the above picture, you can see there is the endoscopic picture of the nose showing the right and left nasal cavity, in which we can see that's the effect of the bottom batteries. Okay, there was mucosal erosion and burn injury at the embedded sites. And then during the procedures, nasal toilet and irrigation was done to remove the crusted lesion as well as the necrotic mucosa. So for this case, the child was discharged well, and during the follow-up, there is no any septal perforation or any long-term complication. That's why we always remember that the bottom battery is emergency ENT and need to be removed urgently. Okay, so important point of the bottom battery. In rare case, false smelling discharge from the bilateral nasal cavity not only suggests infection, but it also indicates foreign body simultaneously in the both nostril. And then the bottom batteries in the X-ray show a double ring or halo density shadow due to the composition difference between its electroplates and plastic chromatic seal. And then always remember that the bottom battery damage the nasal mucosa by a few mechanisms such as thermal injuries, pressure necrosis, and toxic heavy metal absorption. And this injury can continue after endoscopic battery removal for days to which due to residual alkaline or weakened tissue. That's why post-removal, we have to attentively follow up this patient to see any long-term complications such as the septal perforation. So for the next slide, we go with the foreign body in the throat and also the esophagus. The presentation usually, typically the patient will present after the taking meal because they face sensation of the foreign body in the throat. The sensation can be the pricky sensation as well as this occasionally the patient will have dull aching sensation also, especially if the foreign body already lodged for a few days. And then the patient may have odynophagia or dysphagia, vomiting, as well as the drawing of saliva, especially in the pediatric population. Okay, for the examination, usually this case will arrive at the ED first, and then the medical officer will examine the oral cavity. And then if the foreign body is located at the oral cavity, the foreign body may be easily visualized. The foreign body may be lodged at the tonsils, base of tongue, ventricular, and other areas. Usually, if the foreign body in the tonsil, yes, by the oral examination, we can see the foreign body. But if the foreign body already lodged at the base of tongue, ventricular, and other area, we need to perform the indirect laryngoscopy by using the 7-degree scope to see the foreign body. And certain occasion, we perform the neck X-ray, AP and lateral view to see the location of the foreign body. And then CT scan and neck will be performed if suspected embedded foreign body. Okay, this is the X-ray, and then we can see there. I want to show you all the loss of the foreign body shadow at the cricopharyngeal area. You see here, it's already below the cricopharyngeal area, in which the red arrow is pointed toward the foreign body. Now you can see the red arrow there, the below the cricopharyngeal area. So we can see that's the foreign body already beside it, below it. Okay, apart from that, we also perform X-ray to see the radial opaque foreign body as well as the level of foreign body, and to differentiate whether the foreign body in the esophagus or the bronchus. If the foreign body located at the bronchus or the airway, this is also emergency for the ENT because it can cause the upper airway obstruction. For the treatment-wise, so any seen foreign body during the examination is removed at the clinic under 70-degree scope, guidance, and also use of the forceps. However, in case of the failure or deep foreign body location, the ENT will perform the direct laryngoscopy and esophagoscopy under general anesthesia. Okay, that's the case of previously we have the foreign body fishbone, which is located at the esophagus, will be removed by the rigid esophagoscopy. So the instrument for the rigid esophagoscopy, as you can see, a few foreign body that we removed before, such as the coins, and then the long object there is the esophagoscope, in which we really use to remove the foreign body, especially foreign body located at the esophagus. Here, I want to share with you all case of the foreign body in which we encounter in our clinics. Okay, so I try to play this video. Okay, you can see there is the sharp pointing object at the posterior pharyngeal wall, indicate the fishbone. And then this is the 70-degree scope that we have in our clinic. So from the endoscopic view, you can see that the foreign body is pointed towards the oral cavity. Okay, for the second video, you can see the doctor tried to remove the foreign body by using the forceps. Usually during this procedure, we will use the spray, xylocaine spray, to reduce the gap of the patient, and patient will be convenient to remove the foreign body. Some important point in the case of the double coin. The shadow of the double coin in the X-ray may have mimicked the double ring in the bottom batteries of the bottom battery due to it sitting in the same alignment. So for the ENT or ED, they have to differentiate well whether it is the double coin or bottom batteries. It is because the management for this case will be different. For the bottom batteries, it is emergency, which need for the urgent removal of the bottom battery. But for the double coins, In case of the stable patient, surgery can be delayed as compared to the bottom battery, which need to be performed as early as possible. So for the last topic for today, I will describe about the foreign body in the airway also. This foreign body in the airway, even though it is the most rare foreign body in the ENT, but it has high potential for the morbidity as well as the mortality. So for the foreign body airway, the presentation initial phase, patient might have the choking and gasping, coughing, or airway obstruction at the time of expiration. But later on, if the foreign body already passed the vocal cord level, patient may have the asymptomatic phase, in which the subsequent lodging of the object with relaxation of the reflex that often result in a reduction or cessation of symptom, which lasting hour to the weeks. This is because mucosa of the larynx, trachea, as well as the bronchi rapidly adapt to the presence of the foreign bodies. The feature is responsible for the delay in the diagnosis. And the last one, if the foreign body is still not removed after a certain period, patient may have come with the complication phase, in which foreign body producing erosion or obstruction leading to the pneumonia, atelectasis, or the abscess. So we go through the nature of this foreign body after this. Okay, for the presentation, usually for the laryngeal foreign body, the patient will present with the airway obstruction and hoarseness or aphonia. And for the tracheal foreign body, present similarly to the laryngeal foreign body, but without hoarseness or aphonia. And sometimes the patient can demonstrate wheezing. This is similar to the asthma. And if the foreign body lodged downward to the up level of the bronchus, patient might present with a cough, unilateral wheezing, and also decreased breath sound. But this triad only account about 65% of the patient. Okay, I explain certain why the previous symptom happen like that is because, okay, as you can see from the diagram, if the foreign body is lodged at the right primary bronchus, for example, right primary bronchus, and complete obstruction of bronchus happen, can cause the collapse of the lung. So in the percussion, usually percussion of the lung, behavioral dumbness, reduce entry on percussion, on accostation, and also we can see the mediastinum shift to the same side in the X-ray. And then if the foreign body cause the incomplete obstruction of the bronchus, it will look to the expansion of the lung. What is happened? As you can see from the second pictures, the air can go in, but the air can escape. So it's caused the emphysema and also expansion of the lung. So during the percussion, we will notice the hyperresonance. In the accostation, usually we decrease air escape and mediastinum shift to the opposite side. Okay. So the investigation for the foreign body airway, usually we also need to perform the chest X-ray. If the foreign body is already opaque, we will see the under X-ray. Like I mentioned before, if the foreign body completely occlude the bronchus, it can cause the lungs collapse. And then mediastinum shift to the opposite side when partially occluded, like I mentioned before. Always remember that a normal chest X-ray does not exclude a foreign body. Instead, we always go by clinical also. And also, we also can use the 70-degree scope or flexible scope to see whether the foreign body in the larynx or subglottic area. But if the foreign body is lodged downward up to the bronchus or trachea, it's very difficult for us to see it using the 70-degree scope. So for the treatment-wise, for ENT, the most preferred method is we use the direct laryngoscopy and bronchoscopy. It's method of choice, and then usually performed as the emergency procedures and can be a diagnostic procedure if history is suggestive, even without the clinical or X-ray finding. For the emergency cricothyroidotomy or tracheostomy, if indicated, if the endoscopic procedure was not successful, we have this kind of case before, in which it is very difficult for us to remove the foreign body that time. So we decide for the tracheostomy to remove the foreign body as well as sex. remove foreign body that time. And then for the thoracic surgery, it's only reserved for an incomplete removal of the organic foreign body, and then usually it's performed by the cardiothoracic team. Okay, as you can see, there is the instrument that we use. On the left picture is the direct laryngoscope, and on the right picture is the rigid bronchoscope. Okay, this is the instrument that we use to grab the foreign body upon using the bronchoscope, in which we use the optical forceps. Okay, this diagram show the how ENT surgeon performing the bronchoscope, in which we will introduce the bronchoscope via the oral access, and then go straightly direct to the larynx and go downward up to the level of the bronchus. All the procedure performed under general anesthesia. So I would like to share with you case of foreign body in the airway before that we encounter. One case of 18 months old which playing alone in the room that time was noted by his father as unable to talk and cyanus over the mouth. He vomited out the clear fluid that time and had hoarseness, subsequently followed by the noisy breathing and persistent coughing. That time SpO2 was dropped up to the 90% when he cried, and the air entry was reduced on the left side of the lung. So the physician that time planned special for the chest X-ray, and the X-ray show an unilaterally hyperinflated left lung with a poor view of the left main bronchus. That time, no radiopaque foreign body's shadow was seen. Okay, so you can see the picture of the X-ray. Okay, in which the right primary bronchus that in the picture can be visualized. However, for the left primary bronchus is unable to see it. Okay. In view of suspected foreign body that time, we put the patient under GA and we perform the bronchoscopy, in which we noted the peanut occupied the left main bronchus and it was successfully removed with optical forceps. This is the picture on the left side. This is the picture of the peanuts that we take out from the bronchus. Later I will show you the pictures and also the video removal of the foreign body. Okay, so that's the video of the removal of the left main bronchus foreign body. Okay, see, that's the endoscopy video showing the optical forceps that were used with the bronchoscope to remove the foreign body from the left main bronchus. See, the optical forceps was directed toward the foreign body at the peanuts. And then gently the surgeon will try to remove the foreign body. Okay, as you can see, that is the peanut from the left main bronchus. So the surgeon will grab it and attentively and meticulously try to remove the foreign body so that it will not fall down back. Okay, the foreign body already removed. This case looks simple, but basically a few attempts was made already to remove the foreign body. The video only showed the successful that time. Because the foreign body is always, remember that it's always difficult to remove foreign body because it might swell that time, edema, as well as the child might develop episode of desaturation. That's why foreign body in the airway is critical and crucial for the ENT to remove immediately. Okay, I have a second case also to share with you guys. Okay, a 16-year-old baby had multiple visit to ED previously for the cough and noisy breathing. She was initially treated as a croup secondary to viral induced wheeze and discharged home twice after responding well to the treatment. Before that, she had hoarseness and a weak cry following a choking episode 2 weeks ago, and her mother was convinced that the child had vomited the foreign body after she attempted digital removal. Otherwise, the mother claimed that she was active at home between the croup attacks, and on her third visit to the hospital, she was referred to the ENT team for the recurrent croup that time. Remember that previous slide I mentioned to you all about the initial phase followed by the in which the asymptomatic phase and followed by the complication phase. In which during the asymptomatic phase, the child might have no symptom at all, but subsequently, the manifestation will also present in which the child have another episode of the symptom presentation. And upon ENT review that time, the chest X-ray and fluoroscope finding were remarkable. However, we decide this child for the direct laryngoscopy and GA as a diagnostic procedure to see if any probable or not. At that time, upon performing the direct laryngoscope and telescopic examination, we noticed a 1 centimeter thin fishbone was trapped in a sagittal position underneath the glottic region. And then the fishbone was removed using the optical forceps. See, that is the foreign body that we found in the larynx, in which the location, as you can see from the right picture, the endoscopic picture, see, that's the foreign body located as a sagittal view. Sagittal position in which the child still can breathing. However, the child will start having the symptoms if the foreign body is not removed immediately. So this case, because of the irritation, constant irritation of the foreign body that time, caused the patient having episode of virus-induced wheeze, which mistakenly as a recurrent episode of croup. Okay, this last case that I present today, this is the unfortunate case. Even though previous case we see all case we have good outcome, but this case have a mortality. Okay, a 1 year 3 months old boy presented with a shortness of breath to the ED, and then the child previously was fed as a nut by his sister 1 day before the presentation. Since then, he had a persistent cough and vomited food particles. The initial chest X-ray showed no normal finding at that time, and then he was initially treated as a bronchospasm secondary to an allergic reaction to the nuts. While waiting for the admission, he suddenly had generalized seizures and cyanosis, and then the child was immediately intubated. However, the SpO2 was merely around 60–70%, and also there was a reduced entry on the right line of auscultation. And then chest X-ray repeated post-intubation showed the total right lung collapse. The baby was pushed to the OT for direct laryngoscopy and rigid bronchoscopy. However, while trying to insert the flexible bronchoscope through the ETT, he developed pulmonary edema and later cardiac arrest. CPR was performed and bronchoscopy was abandoned that time, and then he was observed in the ICU over the night. And then the child had to undergo another rigid bronchoscopy early in the next day. And that time, the hazelnut was successfully removed from the right bronchus. However, unfortunately, the child succumbed back to death 1 week later due to the multi-organ failure. Okay, that's the picture showing the X-ray. You all can see from the left picture showing there's almost normal chest X-ray, and then the middle picture, that's the X-ray after intubation, after the hypoxic event, in which the total collapse of the right lung. And then the third picture, that's the piece of the hazelnut that was removed during the bronchoscopy. So this child was unfortunate because even though we are able to remove the foreign body, because of the life-threatening event as well as the hypoxic event. Patient lead to the multi-organ involvement, multi-organ failure, and succumb to death. That's why I mentioned, even though we have a few cases before successfully remove the foreign body, but some foreign body may cause the hypoxic event and the child have a mortality afterwards. So important points in the foreign body airways. A definite history of choking followed by a paroxysm of coughing, which the subside is always presentation of the foreign body in the airways, in which is account about 85%. The second one is eye index of suspicion for foreign body in the case of the sudden onset of wheezing in a child not privileged not to have asthma. Always need to consider for the foreign body also. Because like I present in the first case, the child might have ingestion of the foreign body or aspiration of the foreign body without witnessed or noticed by the parent or the caretaker. And then I explain persistent fever also need to rule out the foreign body also. Do diagnostic bronchoscopy if history is suggestive, even without the clinical evidence or X-ray findings. And then antibiotic and post-op chest physiotherapy is a must for infection due to foreign body be present for a long time, so that patient will have a good outcome afterwards. Okay, with that, I finish my CME for today. Thank you for your attention. Any question you can ask me. Okay, thank you.
Thank you, Dr. Muhammad Syarul Hafizi, for the very good and informative presentation. We are now open for any questions or opinion from member of the floor.
If you have any opinion or any experience managing the patient of foreign body, also you can share with us today.
There's a few small comment.
Yeah, Datuk.
You summarize your presentation as a take-home message.
Oh, the one is okay.
Take-home message, because foreign body in the ear and the nose is common, and whether how far we should attempt to remove at the casualty at home, how far. You mentioned just once and try once.
If possible, one only.
So you should have take home message, a simple take home message, so that the MO will do what you want to do. You want us to do, one of thing that other thing that I understand just now, kalau lah foreign body dalam telinga, kita tahu minyak, or put oil inside.
Yeah, Datuk.
That is a good take home message.
Okay,
Suspect foreign body in the ear, taruh minyak, then it goes.
Betul, memang macam tu, Datuk. We always advise our colleagues if the suspect are the living creatures and also the insects, just put the oil first and then see the treatment. So that easier for us to remove. And the second one is the patient will have less pain due to the irritation by the creatures. Thank you, Datuk, for the comment.
Any more questions? If there is no more questions, I would like to invite Dr. Puteri Nurbaya to deliver the certificate of appreciation to our respected today's presenter. Please welcome. Thank you, Dr. Puteri. With that, we have come to the end of the today's CME session. The next CME will be presented by Professor Madya, Dr. Abdul Qadir bin Abdul Karim, lecturer and reproductive medicine consultant at UKM, with the topic of beyond barrier ovarian tissue preservation. Thank you.